The presentation tonight is going to be on special deliveries, caring for the high-risk moms and also their newborns. And it's going to be a little bit of a tag team back and forth among the speakers. A really thoughtful presentation going from the history down to present day.
Our first speaker, and as Joanne said, they're going to alternate back and forth, but Tom Benedetti is he's really an icon of education and clinical care here at the medical school. He's a professor and vice chair of the Department of Obstetrics and Gynecology here at the medical school. He's a research affiliate at the University of Washington Center on Human Development and Disability, and the associate director of our simulation group, which is the Institute for Simulation and Interprofessional Studies, or ISIS. He's a really local boy done good and has hung in there these years after a brief sojourn to Southern California, where he did his residency in obstetrics and gynecology. And down there he learned to love deep sea fishing in the Pacific. And this guy can catch a slippery baby as well as a 25-pound king salmon. He's got this king salmon in one hand and his beautiful granddaughter Zoe in the other, both with a very firm, stable grip so they don't hit the floor. He did his fellowship in maternal and fetal medicine at the University of Southern California, Los Angeles, and also a master's degree here at the University of Washington in health administration. His chief clinical interest is in birth trauma and injuries sustained by the infant at the time of delivery. And he serves on the editorial board for the Society for Simulation in Healthcare, and he's also the chair of Patient Safety and Quality Committee at the Institute for Simulation and Interprofessional Studies. And here he is again with his, probably one of his larger catches, a 100-pound tuna caught off west of Cabo San Lucas. So he is really a guy with strong hands. He's the guy you need catching that baby in the middle of the night, not only doing that himself, but making sure that generations of obstetrics physicians are going to do it right for many decades to come. So it's a real privilege to introduce Tom, who's lectured and published widely on a whole variety of subjects and presented at many simulation conferences and universities around the whole country. So the other presenter, Joanne?
Once Dr. Benedetti catches the baby, if they're premature, he turns them over to Dr. Christine Gleason. She is the Allen Hodson Endowed Chair in Pediatrics, and she's a professor of pediatrics. She's actually chief of neonatology here at the UW Medical Center and Seattle Children's Hospital. For those of you that don't know what neonatology is, they will be describing it this evening. She is an affiliate research investigator at the University of Washington Center on Human Development and Disability. She also is a member of the Seattle Children's Research Institute Center on Integrative Brain Research. Historically, she obtained her medical degree from University of Rochester. She then moved to Case Western, where she received her residency in pediatrics, a neonatology fellowship. She is recognized locally, nationally, and internationally. This shows you a little bit of the local recognition. Seattle's top doctor, Seattle Metropolitan Magazine and Seattle Magazine. At a national level, she actually was on the board of directors for the American Board of Pediatrics. Her chief research interest lies in the effect of medications that we give to these young neonates, the effect of drugs such as cocaine and alcohol. And if you think about these young babies in the intensive care unit, they may be suffering from pain, stress. One of her current research interests is studying the effects of morphine that's given to these babies to try and help ease their pain and discomfort. She's a storyteller. She recently published a book entitled Almost Home: Stories of Hope and the Human Spirit in the Neonatal ICU. And you'll be able to tell this evening that she really is a storyteller. Some of the reviews describe this book as an engaging, feel-good book about a remarkable woman's career in medicine and the exhilaration of saving young lives against almost impossible odds. And they'll show you pictures of these very, very small babies. Another review from Seattle Times described Dr. Gleason as a terrific storyteller. She is frank about her successes and shortcomings and deeply involved with her subject. And finally, Dr. Newland, who's been a professor at Yale and other institutions, stated the following. He says, "The neonatal ICU is a place of wondrous skill and deep compassion. It's largely because of the leadership of physicians like the remarkably gifted Christine Gleason. We are very lucky here in Seattle to have combinations of physicians like Dr. Benedicti and Dr. Gleason that can cover the whole spectrum of care, from the delivery to the care of the child." So join us in welcoming the two speakers. That's yours. Okay.
Well, thank you. When people say those nice things about you, I suspect I speak for Christine. The first thing you wish is that your mom was here to hear it. And then the second thing you think is, who are they talking about? And so tonight, and I noticed when they did our CVs there, that you didn't see any dates on there. And there's a special significance to that. And what we're going to talk about tonight really spans our careers in these two fields, because when we started in medicine, both of us, these fields literally didn't exist. And so we're going to tell some stories about the way things used to be, how things developed, and then a little look into the future, into what current successes and what sort of problems some of our successes have generated. So Christine's going to start, and please welcome her to the stage.
Thank you, and thanks for that wonderful introduction. It is really a pleasure to be here and to talk about this subject, which is very near and dear to my heart. So as Tom said, I'm going to start by talking a little bit about the history of my field, and first to tell you what is neonatology. It's important to realize that a neonate is a term that actually was developed a long time ago, but not as recently as you might think. And it's a baby who's less than a month of age. So it encompasses newborns, but also in the first month of life. It's a hospital-based specialty that we practice that's a subspecialty of pediatrics. And it's usually practiced in neonatal intensive care units. So like I don't have an office, on First Hill where people bring their newborn babies. The common diagnoses are prematurity, birth defects, infections, and other birth-related problems. One of the things that I think illustrates the best how we've advanced in this field is the infant mortality statistics. If you look back over the last 100 years or so, in 1915, here in the US, 100 babies died for every 1,000 live births. So if you had a baby, it was a 1 in 10 chance that your baby would die. By 1960, you'd think we would have made a lot of progress, and we did. But in 1960, there were 60 deaths, infant deaths, per 1,000 live births. And in 2004, were 6.5 deaths per 1,000 live births. So there have been a lot of reasons why I've been privileged, and Tom too, to participate in this enormous advance in our infant mortality rates. But as I'll show you, and we'll all talk about at the end, we still have a ways to go. So how did this all happen? Where did it start? Some of it is prematurity. We take care of really tiny babies too, and I'll talk a little bit more about that. Well, so here's where some of it began. In 1889, or really a little bit before then, people discovered that if you had a small or premature baby, if you were able to keep that baby warm and able to give it some nutrition, generally like a bird dropper, something like that to get milk in, these babies could survive, where previously they were all weakling, sickly, and died. So there were set up these charity incubator businesses where people would bring their small babies, and here were some nursing staff in Paris who would take care of them. Well, it was realized quite quickly by people that this was an oddity. It was like a circus act. Everybody wanted to come and see the little babies. And so this is what happened. They became a World Fair exhibition. Here's the guidebook from 1915, San Francisco International Exposition or World's Fair. So it says here, the appeal of the helplessness of the unconscious mites of humanity, rescued and thriving in spite of adverse fate, reaches alike the specialist and the careless sightseer who may learn here the particulars of nourishment, nurture, and care given these incubator babies. Here's a picture of the pavilion. It says infant incubators right there, if you can't see it. And here's all the people. You can see where people are actually, allowed to walk around these edges here. And here's the nurses, and here's the little babies there. And here's a couple of the pictures. You can't really see the babies in there, but they're in there. And of course, some of them in the morning, people would come in, and a few of them would have died. And then they would be replaced by others to go into these boxes. There was some recognition that maybe there was a need to do a little more than that, than exhibit them in world fairs. This is Dr. Ballantyne, British Journal of Medicine in 1923. There's a need for specialization in neonatal medicine. This applies to doctors and nurses, as well as teaching and construction of hospitals. The specialist in neonatal diseases and the nurse intensively trained and expert in the management of delicate newborns will be commonplace ere long. I love the way they wrote back then. In the 1930s, Dr. Greeley, this is the President's address to the American Pediatric Society in 1939. In previous times, the problems of the newborn child have been the province of the obstetrician. No offense to Tom, a field in which he has taken comparatively little interest and to which he has contributed little. As pediatricians, we have but scratched the surface. Now I'm going to move up to 1956. This is my family in 1956. I bet you can guess which one is me, looking right at the camera. Of course, I have the baby doll here. Actually, there's two. You can see the legs sticking out from the other one. That's my sister, not a doll, one of my sisters there. So what was happening in the 1950s? Well, a big deal for the obstetricians with difficulties that they would have with the babies that came to the mothers with Rh disease. This was a huge problem. And it's, Tom's going to talk a little bit about this later. Hemolytic disease of the newborn, this is where the mother's blood type and the baby's blood type don't match. And so there are antibodies that are built up. And they break down the baby's red blood cells. So the babies are anemic, and then when they're anemic, they actually get swollen, their livers don't work well, and they get very, very jaundiced at birth because of all these broken down red blood cells. So it was discovered, it's just one of the very first things that was done in neonatology, that if you did an exchange transfusion of the baby's blood, take out the bad blood, put in good blood that didn't have these antibodies to break down the baby's blood cells, babies could survive. And better, they could survive without brain damage caused by the severe jaundice. Well, they couldn't do these exchange transfusions. You couldn't get blood from these little babies, from even a normal term baby. It was very difficult. You know, everything was adult size. So people figured out how to put catheters in the umbilical blood vessels, one in the artery and one in the vein. And that's how they did these exchange transfusions of all this blood. So that was a huge advance, not just for that disease, but also because now there was a window into the baby where we could get blood to measure certain things like the oxygen level, the jaundice level, other things like that. And we could give fluids and nutrition and medications through the vein. The other thing that happened in the 1950s was the APGAR score, Virginia APGAR. It signed the baby's first grade. You know, did you get an A or B? Well, these are numbered scales, and they tell us how the baby did at the time of birth. And the important thing about the APGAR score was that what it really meant was that somebody had to pay attention to the baby. There was all the effort was on the mother, and as Tom said, there was good reason for that. Mothers died in labor and so forth. So everybody was paying attention to the mother, and then the baby would come out and not be breathing, and there wasn't anybody there for the baby. So now you had to assign a score, and it included breathing, heart rate, and so forth. And so this was a big advance and sort of brought the field up a little bit. But still, we had a long way to go. This is one of the fathers of neonatology, Dr. Bill Silverman, his reflections on what it was like in the 50s. The premature nursery was a backwater of the hospital. Physicians weren't much interested in it because they had so little to offer. Nurses were all powerful, and it was primarily nursing techniques that sustained the infants. And here they are. And I don't know if you all can appreciate this in the back, but here's a couple of nurses with one of these, and now we've advanced, right? We've got a box in here. We're not at a World's Fair anymore. This is a baby right here, a little premature baby, huge tanks of oxygen, and there's a stethoscope. It's the same size as the baby's head. I mean, it's really pretty amazing. And the baby, if you actually can see this really close, the baby's eyes are wide open. It was like, oh my God, what are you doing to me? So it was, and here's some nurses here with a bunch of premature babies showing off their skills. And lastly, you realize in the 1950s, it was still, what, Tom, about a third of babies were born at home. Something like that, maybe half at that point. And so babies would be born prematurely and little and need help. And you had some hospitals where things could be done, but you had to bring the baby there. So here was transport to the premature baby ward. It says here, premature baby ward, a couple people with an ambulance and a basket, and there's a baby in there. It didn't go well. This was a big stress for these babies. All right, I'm going to turn it over to Tom.
Okay, so get out your clickers. Everybody got a clicker? As Christine said, she is a neonatologist, and I am a perinatologist. Perinatology is a subspecialty in obstetrics and gynecology. People that do this train for 4 years in obstetrics and gynecology, and then do another 3 years training in high-risk obstetrics. Also, you'll hear it called maternal fetal medicine, and it really focuses on the care of high-risk mothers and fetuses. These might be moms who have diabetes, high blood pressure, or babies who are identified in utero with certain birth defects, or, as we're going to talk about in a minute, RH disease. So I want to see what you have to say about this. So this first question is, what year were you born? Click 1 if you're 1930 to 50 or before 1930. Click 2 from 51 to 70. And click 3 if you're born 71 to 1990. And if you were born after 1990, you should be home studying. A lot of people born in an early era. And as we go down, so it's about a third, and a third. So the next question, what is your estimate of the risk of your mother dying about the time you were born? People don't like to talk about this. We don't talk about it very much. That isn't the first thing you talk about when you see your obstetrician. So the risks here are 1 in 100 all the way to 1 in 100,000. And the answer, so we have about 17% say 1 in 100. About a third say 1 in 1,000. 1 in 2,000, some 1 in 10,000. So the answer to this question is that many of you are right, and it depends. And it depends when you were born, because if you were born between the years of 1920 and about 1940, the chance of your mother dying in childbirth was about 1 in 100. Just about the number that Christine said for infant death. And I got in a lot of trouble when I came to Seattle in the early or late 70s because people kept talking about natural childbirth. And I sometimes make inflammatory statements, and I made the statement, well, the most natural thing about childbirth is maternal and infant death. And it's only when you start to provide safeguards to that that you get out of what happens to the natural environment. Well, you can imagine I wasn't real popular with certain constituencies, but that's the data. And so if we go into the time, around the time that I was born, around 47 or so, you can see the mortality's dropping. And so if you were born in that second era, your chance of your mother dying was about 1 in 2,000. Now, the data shows that the chance of a woman dying from childbirth is about 1 in 10,000. But that number has been stable for a long time, and the gross estimates are that about a third of those could be preventable, so we still have a ways to go. And what are some of the reasons? Well, this slide is current data, and it shows the maternal mortality related to the proportion of deliveries with a health professional in attendance. And you can see that the maternal mortality is very low when there is a health professional in attendance, and those numbers go up to 1 per 100 or higher when the incidence of health professionals in attendance at the delivery is 10% or lower. And these are happening all over the world. These are the developing countries, many of them quite undeveloped and struggling to provide safe maternity services. And this is what the data look like as best I can find, because this data isn't always available, for the incidence of cesarean section and what we call operative deliveries, that is either forceps or vacuum or cesarean deliveries, as early as 1960 to 1975. And you can see the cesarean section rates were quite low, 5 to 10%. The forceps delivery rates were actually quite high, as you'll see, because I'm going to expand this slide as we go on. And the spontaneous delivery rates were about 50%. And as my mother told me, I was born in a typical fashion in 1947. They gave her inhalation anesthetic, put the forceps on, and dragged me out, as they say. That was a very, very common method of delivery in the 40s, 50s, 60s, and 70s. This is an artist's rendition of old-time forceps delivery. Those of you with any animal husbandry experiences will know that that's the way you deliver animals, with blocks and tackle. We now have much more modern instruments. This is a forceps delivery. We sometimes put small suction cups on the baby's head to help it out when the mother can't give spontaneous birth. As Christine mentioned, I'm going to spend a few moments talking about a significant success in these early days, our first real medical success in both neonatology and perinatology occurred with Rh disease. As she's explained, this is a disease where one pregnancy sensitizes or immunizes the mom against the red blood cells of the baby. In subsequent pregnancies, then the antibodies go across the placenta, attack the red blood cells of the baby. It gets very anemic, sometimes dies. Prior to 1960, this disease affected 10% of all pregnancies. And it was mild to moderate in some, but the hydrops was a severe disorder, and when the babies got hydropic, they nearly always died. What happened was we figured out that if we prevented the mother from recognizing the baby's red blood cells as foreign, we could prevent the sensitization. And the way we do that is we administer a stimulus to Rh negative males. They develop the antibodies. We harvest the antibodies from them. We remove all the viral particles. And now we administer this substance called RhoGAM to the mothers to prevent the sensitization. We initially did it in the postpartum period only, when a mother was Rh negative and delivered an Rh positive fetus. But along the way, we noticed that there was still a small fraction of mothers who would become sensitized. They became sensitized during the pregnancy. And so we now administer this to mothers at 28 weeks and at term. And this has virtually eliminated the disease. There are a few little pockets left. Most of them are not Rh disease, but they are other irregular antibodies. It was sort of sad to see this go in a weird sort of way because we got really good at treating this. We developed techniques for trying to assess who was sick by measuring antibody levels in the mother, and when they reached a certain level, we did amniocenteses. Here you can see the kind of graph that we used to use. We would take the fluid and measure it against a standard curve, and the curve should go down as the gestation progressed. If the curve was going up, that meant that the baby was hemolyzing more and more red blood cells because what we were measuring was the bilirubin levels in the amniotic fluid. And we got really good at then giving the baby transfusions in utero. This was the first intrauterine fetal therapy and probably still the most successful one that we ever did. Along the way, we got a little smarter. And I always laugh when I show this slide because many of you remember Dr. Jack Lean was an obstetrician here, was a health sciences director for a long time. And Jack was a very funny man, and he always used to say, you know, there's 3 principles of cardiopulmonary resuscitation. Air goes in and out, blood goes round and round, oxygen is good. And along the way, we figured out that the baby, when it became anemic, the blood went round and round faster. And we now have Doppler ultrasound techniques where we can measure the speed of the baby's blood in the brain and extrapolate how anemic the baby is, so we don't need to do the amniocenteses anymore. So in a non-invasive way, we can predict who's getting sick and who isn't. We can either do a transfusion or deliver the baby. And this is data to show you what happened at the University of Washington. We actually had, for non-hydropic babies, the best perinatal survival in the world, as it turns out, 100% over a long period of time. For hydropic babies, we didn't do so good because we hadn't developed intravascular techniques yet. Now with intravascular techniques, most, not all, but most of the babies can be transfused and saved. And what's happened is that very few perinatologists even have any experience with this anymore because it is so uncommon. So this has been a real success story for perinatal medicine, the sort of model of which we would like to base many of our other therapies. Christine?
Well, continuing with the historical theme, these are some famous preemies in history. Isaac Newton, Voltaire, Napoleon, some of them are kind of short, Albert Einstein, Anna Pavlova, and Stevie Wonder. And actually, Stevie Wonder is blind from the retinopathy of prematurity, the eye disease of prematurity. He was born in the 1940s and was an approximately 32-week preemie. And in those days, he was in one of those incubators, and all you could get was 100% oxygen. There was no way to adjust it, and that basically burned his eyes so that they didn't develop properly. What I'm going to focus on in the next several slides is maybe not necessarily the most famous preemie, but the preemie that, in my view, changed the future of neonatology and created our field. And that's Patrick Bouvier Kennedy, who is the infant son of Jacqueline and John Kennedy, president. He was born and died in the year of his father's death, 1963. And the obituary in the New York Times said the battle for the Kennedy baby was lost because medical science had not advanced far enough. So what happened? This is actually from a master's thesis from a student, Christina Page Jones, in 2001. She wrote about the end of Camelot. They used to call that for the young folks, that John Kennedy's administration was like Camelot. What was there at the time? Well, the touch-tone phone was introduced by AT&T, and Betty Friedan wrote The Feminine Mystique, and the best motion picture was Tom Jones. Surfing was a new fad, and so a popular song was Surf City. Well, that all was background to Jacqueline Kennedy becoming pregnant with was her 4th pregnancy. And what I've done here is write this as a case history, as you might read in a patient's chart. So this is about their son, Patrick. This was a 4-pound, 10-ounce, 36-week gestation preterm male infant born to a 33-year-old, gravid of 4, that's 4 pregnancies, para 2, 2 live-born, and 1 stillbirth. Married woman with a due date, that's her expected date of delivery of September 5th, 1963. Mother smoked 1 to 2 packs per day of cigarettes and received occasional injections of amphetamines from Dr. Feelgood for anxiety relief, quite common at the time. The delivery, the baby was born by repeat cesarean section because Mrs. Kennedy had had previous cesarean section. After she developed premature labor while taking her children to a riding lesson while on vacation in Cape Cod. The baby developed respiratory distress, and which was not expected. He didn't have that to begin with, but he was then taken by ambulance from Otis Air Force Base on Cape Cod to Boston Children's Hospital because of this breathing difficulty. Remember, he was 1 month premature, 36 weeks, 40 weeks is the due date. He was stable initially in 100% oxygen, that's what was done in those days, until he acutely deteriorated at 38 hours of age. They tried a negative pressure oxygen chamber in the hospital basement, but he died at 40 hours of age, and his father, the president, was present at his bedside. The causes of death were listed as prematurity and RDS, which stands for respiratory distress syndrome. And one thing that's probably not well known is that, but you can read this if you look at newspaper articles from the time, that there were no places in the US that could take care of a baby like Patrick Bouvier Kennedy, who was premature and had lung disease and needed to have some respiratory support, like with a ventilator. There were no infant ventilators developed enough, even at the famous Boston Children's Hospital. But there was at the Hospital for Sick Children in Toronto, Canada. And President Kennedy decided not to send his child outside the United States for care. But you can imagine, after a baby dies 1 month premature and dies of RDS, and it's the president's son, that this set in motion a whole lot of effort to try and improve the outcome of pregnancy so that no other babies would have to die like that. So NICUs were built, neonatal ICUs. Here's a NICU at Stanford in the 1970s. These were big, bustling places. It's always hard to find the baby in here. There's the baby. Stethoscopes are a little bit smaller. It's mostly men in those days. These are all neonatologists. This is actually David Stevenson, who was John Stevenson, who was director of surgery here for a number of years. It's his son. Was born in Seattle, then went to Stanford. This was another NICU in the 1980s, and probably what's impressive to you, again, you're putting all this equipment and babies. This was actually a 6-bed NICU in the 1980s, and at the time of this photograph, it had 12 babies in it. And they're all over each other. I mean, see, they're kind of small, so when people were thinking, well, we're going to make a NICU, and the hospitals were all excited you could stuff a whole lot of babies in one little room and all these little pieces of equipment and so forth. So this was not a very family-friendly place to be with your child. Here was an old infant transport incubator, and there were new ones that were developed. Here is one that actually is from the modern era that is actually portable, so you can take it on an airplane. This is one of our air transport incubators. So a lot was going on to build these units, incubators being a main thing, and a lot of effort made to get these catheters put in those umbilical vessels that I mentioned to you, so you could do things with nutrition. Infant formulas were developed, all sorts of things. But what about what babies died from with their prematurity and the premature lung disease? research was really needed in order to figure out what was the cause of this problem and then how do you treat babies with it. And that was the focus of the next 40 years and has really been responsible for that huge improvement in infant mortality that I showed you. So there's a lot of equipment that goes into this. Here's a baby on one of the websites. This baby actually has a birth defect, is not premature. But you can barely, can you imagine being a parent and then you're seeing your child like this? But these are all things that have been developed over the years to keep these babies alive. Here are these umbilical vessels, catheters in here, taped in place so they don't come out. Isn't it nice that they have little heart-shaped temperature probes? Usually they put that right over the heart, but a tube going in the baby's nose in this case to connect to a ventilator. So this goes down the baby's windpipe, a feeding tube, a chest tube to get air, extra air out. Here again are those umbilical catheters. So a lot of equipment, a lot of things, but what do you do with it all? This was one of the greatest advances that was made. And the big focus here, of course, was on RDS, respiratory distress syndrome, what Patrick Bouvier-Kennedy died from. So what is that? And why does this contraption help these babies? Well, actually, some of that work was done by my predecessor here and a number of his colleagues to figure out what the problem was with RDS. Why did premature lung disease cause these babies initially to come out looking okay, and then they started working hard to breathe, gasping, and needing support. And sometimes there was nothing you could do and they would just die. Sometimes you could give them a little oxygen. Well, it was discovered that there's a substance in all of our lungs called surfactant. It's a liquid soapy material. And it was discovered very serendipitously that babies who have RDS are missing this soapy substance in their lungs, just because they're premature. Well, what does it do? Well, if you think about it, and most of us do not think about breathing, right? But if you stop and think about it, suddenly you're breathing like this, right? Because you're thinking about it. Well, most of us, when we think about breathing, we think you take in a breath and you blow it out, and it's like a bellows, right? You open up your lungs and all those sacs, and then when you blow it out, it's like this. Open, close. But that's actually not the way it is. You take your very first breath, which is a once-in-a-lifetime experience. Take your first breath, and you open your lungs, and then with your next breath, it goes like this. It does not collapse down. All those millions of air sacs you have actually stay open so that it's easier to take the next breaths. And what does that? Surfactant. It's that liquid soapy material. It has to do with surface tension in the lungs. So premature babies don't know they're supposed to have all this surfactant, and so they don't make it. And so what happens? The baby takes a nice breath, they cry, you slap them, do all that stuff, they open up, but then close. And the next breath is harder and harder and harder. And after a while, they can't get the lungs open, and they collapse. And that's what makes them breathe harder and harder. So what does this do? Well, this was a contraption that was actually invented. It's not a ventilator. It's called continuous positive airway pressure. And it's basically pushing through the baby's nose and mouth like you would do if you were grunting. So if you go like that, you can see, oh my gosh, well, what happens to your lungs? Well, it sort of pushes open your lungs like that. And this does it for the baby. So the baby is grunting, trying to do its best to keep the lungs open, and CPAP pushes pressure against the baby's lungs and through the mouth and the nose and keeps it open. This was a miracle that you could do this. You didn't have to put the baby on a ventilator, didn't have tubes, things like that. So this was going on in some of these NICUs around the country while people like Dr. Alan Hodson, my predecessor, was trying to figure out, well, what's the pathophysiology for this disease? And why do babies have complications from it? And how can we ventilate them if we're going to use ventilators so that they don't rupture their lungs and they don't die like President Kennedy's son died in the basement of Children's Hospital? Well, at the same time, once people figured out what caused RDS, and it was this lack of surfactant, it was like, well, gosh, why don't we give babies surfactant then? So what a great idea. And actually it was our Japanese colleagues, Dr. Fujiwara, who made the first discovery that you could actually get this surfactant material out of amniotic fluid. Let me tell you, you needed gallons in order to get enough of this stuff so that you could actually treat a baby. And Dr. Fujiwara, what did he name it? FujiSurf. I just love that. So, and FujiSurf is actually the predecessor of the surfactant that we currently use here at University of Washington Medical Center. It's soapy. If you feel it, it's soapy, just like it is in our lungs and so forth. And what we can do, this is an X-ray of a baby with RDS, and here's the, so these are the lungs. The white stuff is an organ. So you guys are all, you're in medical school, right? So you know all this stuff. I'm probably talking down here, but so this is the heart here. The lungs should be dark because air is dark on X-rays, and you can see they're all white. That's because they're collapsed down. The baby has RDS. And so here's the endotracheal tube that we put in, that at birth or after the baby is getting respiratory distress, and we literally pour that surfactant material in there. It's equivalent, what we give these babies, to the volume would be as though I poured a can of Coke down one of your lungs. That's how much it is. It's a lot of liquid, and it kind of bubbles up and all that sort of stuff. But look at the difference. This is 3 hours later. Lungs are expanded. They're all nice and dark. It's a miracle. It changed our lives in the NICU. NICUs went from places where every baby was on a ventilator, sometimes for weeks and months. Lungs were ruptured. There were pneumothoraces. And now you walk in them, they're quiet. There are a few babies on a ventilator, this and that. It's just been a miracle. It's one of the true, real advances, in addition to being able to use CPAP and ventilate these babies in a safer way. So a lot of effort made on figuring out this disease, focus on the newborn lung, in part driven by our president and by our administration, because this was a bad mark on American history. Well, the lungs are not the only organ that are affected by prematurity. And this is a photograph, a pathologic photograph of a baby who died, a premature baby. And the brain is filled, the inside of the brain, with blood. This dark material is all blood. This is a severe brain hemorrhage that this baby suffered, in part related to prematurity. We don't know why this happens in babies, and we've spent the last several decades trying to figure out ways to prevent it, or at least ameliorate it, make it less severe. We did figure out how to use an ultrasound machine to be able to diagnose this terrible calamity. And this is an ultrasound of a baby's brain, very similar to what I just showed you on the pathology. And this white part here is blood in the inside of this baby's brain. And this is important not only in counseling parents, because if we couldn't see it before, we didn't know. These hemorrhages, if babies survive them, are associated with a much higher risk for severe handicaps later on. But in addition to that, if we couldn't figure out how to diagnose them early on, then how could we decide whether any protective therapies worked or not, if we couldn't figure out who actually had these? So this has been a big advance, too. Another thing that's happened as we've evolved over these last several decades is in our training. For all these myriad of procedures that are done. You know, I've been in this business now, well, I guess I can admit it now, for about 30 years, starting with my training in 1979 as a pediatric resident. And it took me a lot of practice to be able to, this is a picture of a premature baby in the delivery room. And this person is putting in this endotracheal tube. This is intubating this little tiny baby. This is not an easy procedure to do. It's not an easy one to teach. And yet, you know, if I tell people, I say, well, you know, who's going to be taking care of my baby? Well, I'm going to be supervising it and so forth. Well, are you going to intubate the baby? Well, we're a training program and so forth. And say, well, no, I want you to intubate the baby. And of course, I never say this to parents. But the truth is, you know, if I do all the intubations, then who's going to intubate my grandchildren when they need it? We have to train the next generation. But of course, we have to train the next generation safely. We can't hurt babies doing it. So what's developed are these wonderful sim babies. This is sim baby. So, and they're getting better and better. So I mean, obviously this baby's huge in comparison to that little tiny baby, but we're getting there. So we have all sorts of things that we're using in training for our residents, for people who are training to be neonatologists, and actually also for us old folks, you know, to keep up our skills. Because people question it. Well, you know, you get to be close to 60. Well, can you still intubate? You know, I mean, I've got to get my reading glasses on, you know, things like that. So it's important at both ends of the spectrum, training, but then in keeping up our skills. So these ISIS, like where Tom works and so forth, with these SIM centers, we're using these a lot. So the last thing that I'll just focus on before I turn this over to Tom, again, taking us back over these last 40 or 50 years with remembering President Kennedy's son being transported, being delivered at Cape Cod, and then transported to the basement at Children's Hospital. So what needs to happen, or needed to happen, was that babies needed to be born at the place that was going to be best able to care for them. Not have to be transported, popped in an ambulance, a basket, like in the old days, when they're sick and they're distressed, and taken in. So you had to have these maternity hospitals, hospitals that delivered babies, develop capabilities for their care, for the care of these babies, and then make sure that the mothers who were at risk for having the babies who need that care delivered there, and you didn't transport them in. Children's hospitals were developing simultaneously, and I think most of you probably realize, but not everyone, that like our children's hospital here in town, we don't deliver babies there. Babies are all transported in there. It's not a maternity hospital. And yet that's where a lot of the surgical and really high-tech quaternary care is centered. So that's an issue all over the country, but there's no question that it's better for babies to be cared for in the place where they're delivered, not to mention that it's kind of nice for mother-infant bonding, not to have your baby suddenly taken away from you and transferred miles away at a place that has a higher level of care. So this is actually our own. This is what we used to be called, right? University Hospital here. So this is just an early example of this. So our NICU, which we had here, Ellen Hodson founded this NICU here, 1974, of the 250-some babies that were admitted to the NICU that year, the vast majority were babies transferred in from elsewhere, all over the place, that came in. And very few of them were the product of a maternal transport. The mother was brought here to deliver the baby. And then look what happens over the course of the 1970s. So now you get to 1978, 400 babies admitted to the NICU. The majority of them, or a good percentage of them, are because the mother was transferred here. So they're inborn. They're born here, they stay here, they get the higher level of care. And much fewer are transferred in. Lastly, and I just love this is Jerry Lucy, is one of a neonatology colleague, just a revered person in our field. 1973, a recent criticism of intensive care, this is neonatal, is the expense of perhaps $200 a day for a sick infant requiring care for several days. If this argument is raised, it should be countered with the fact that the costs of doing nothing are, in the long run, actually more expensive, can easily run to $250,000 over a 40-year lifetime. So people were debating this back then in the 70s, is it worth it and all that. Well, of course now, an average hospital cost for a premature baby who's in the unit, for our unit here, for a month or two, it will run to $250,000 for the admission itself, and then you have all the other costs with follow-up. So I'll leave you to think about that. I think it's worth it.